quickly, my disclosure, as you heard, I'm a general surgeon. I pale in comparison technologically to the previous speaker, but I now work full-time for the CMPA. I work for you essentially. I don't have anything that I need to disclose. What we're going to talk about is challenging encounters, and in 20 minutes, and I promise we'll get you back on time, in 20 minutes it's a pretty big topic to cover, so I'm going to do an overview basically of what those challenging encounters can look like, their impact, and what we can do about them. I will point you to some other resources at the end as well that can give you some more details. I mean, if we went around the room and asked everybody for examples of challenging encounters, I'm sure we'd come up with a ton of narratives, actually, of different situations. But I think they would all fit into some of these big categories, basically. Patients asking for forms to be filled that we don't think they're really candidates for, drugs or treatments that we don't think they need. Sometimes it's not actually the patient, it's the family behind them that's pushing them forward and aggravating the situation. Many times it's about unrealistic expectations. Patients expect something that we really can't deliver on. So all of these situations are tough situations that we find ourselves in, and tough situations that the patients find themselves in as well. And it does have an impact on both the patient and on us. It's very clear from the literature that patients that are labeled as challenging patients, patients that have these challenging encounters, are more prone to harm from medical care. And on the physician side, well, these challenging conversations are stressful. They often put us in an emotional state. And again, we all know from psychology that when we're in an emotional state, we're not as smart as we are. It increases our cognitive load, and we don't make as good decisions. And so we're more likely to have errors like diagnostic errors, for example, which then impact the patient. Potentially you have patient harm. If you have patient harm, again, erodes your wellness because it stresses you, which makes you more prone to make more mistakes, and so on. That vicious cycle continues. So how do we deal with this? And what I'm going to propose is that there are basically three things that we need to do. The first is to build that foundation, and that's the foundation of trust between us and the patient, which is fundamentally sits in the way we communicate with the patient. And that's important because when we encounter these challenging situations, and we will encounter them, if we've built that trust relationship to a sufficient level, we know the challenging moment is going to erode that trust, and the tools that we're going to use to rebuild that trust will only work so well. So we need to have that trust relationship worked on. And finally, if that doesn't work, then what do we do if none of our tools are working? So the first tool about building the foundation, I think the first piece of the foundation is what you do in your whole work environment. And by that I mean policies and procedures. I give you an example. About a year and a half ago, I finally got a family doctor. It's very hard to get a family doctor in Ottawa right now. And when I joined the practice, I was given a 2-page pamphlet, and it described how the practice worked. And an example was, it said, appointments are 15 minutes in length. If you show up late for your appointment, you don't get 15 minutes, you get the balance of whatever 15 minutes is left. If you're more than 10 minutes or more late for your appointment will be canceled and rebooked at another time, maybe later the same day, but you won't, we're not going to delay all of the patients on account of you. And those same statements were on posters, in the waiting room and in the exam rooms. So being aware, setting those expectations of how the practice works helps to create that trust environment. Now, it also helps, and it's very important to be consistent in those applications. I mean, if I show up to my family doctor and I always get 15 minutes, even though I'm 10 minutes late, then the policy is meaningless. And when that situation arises where all of a sudden I'm cut off, I'm probably not going to be very happy. The other part of that sort of foundational piece in your work environment is something that I think everybody has nowadays, which is these posters or signage that points out the fact that disruptive or aggressive behavior won't be tolerated. And if you don't have that, you definitely should. You can download these from multiple sites. Now, finally, the important piece is that foundation of trust that you're going to build with the patient. Now, I'm sure in a room with this number of physicians, there's probably quite a number of you who are experts at creating that trust relationship with your patient. But one of the things I think we tend to ignore, and I bring it up only because in the last couple of years, I've joined that club of the slightly hearing impaired elderly people, is can the patient hear you? I mean, it's great that we can communicate, but can we actually hear you? And if you look at the statistics, about 20% of people above the age of 20 have a measurable hearing loss. And if you go up into the older age groups, around 70 or so, that goes up to about 65, 70%, yet only 20% have any kind of hearing aids or assistance. So they need to hear you. It doesn't matter how good your communication is. And there I speak from experience, again, of not having great hearing. And if somebody's not looking at you when they speak, if their head is buried in a document or a computer or facing away from you or mumbling, yeah, you hear some of it, but you don't hear the whole thing. So always take that into consideration. So how else? What else do you do to build the trust? Again, as a surgeon, speaking to a group that contains many family doctors who are probably experts at patient-centered communication, I feel a little foolish, but it is really about that patient-centered communication style that helps us create that trust relationship. And you're probably familiar with all these different frameworks, but I'll zoom over to the last one, the FIFE technique. And the acronym stands for feelings, ideas, functioning, and expectations. With this particular tool, I would say, all of the patient-centered communication frameworks contain the basic core elements that are very similar. The one I think we need to really pay attention to, though, is expectations. If you look at medico-legal data, and if you look at the literature, one of the main contributors to patient complaints and lawsuits is a failure to meet patient expectations. And I think these frameworks basically are encouraging us to be very proactive about asking the patients, well, what are your expectations? What did you think was going to happen today? What do you think this treatment or this surgery is going to do for you? What is your outcome going to look like? Being very clear about those expectations is important because if they are expectations that you know aren't totally realistic, it is your opportunity to reframe them, and in reframing them, resetting the patient's expectations, or at least creating that knowledge with the patient that those expectations are not totally necessarily attainable. Now you can build this trust relationship. You can use these patient-centered communication skills, and you use them every day. But events will happen. Delays in treatment, diagnostic errors, a form that has to be filled that you don't think needs to be filled, an antibiotic that you don't want to prescribe. Those things will happen and come to challenge the encounter that you're going to have with the patient. And the communication tools that you're going to use in those types of situations shifts a little bit, and it shifts more towards that de-escalation, negotiation type of environment. Again, there are volumes written, books and experts on negotiation and de-escalation, but there are tools very specific for medicine that you can use as well. The one that we promote at Learning in the CMPA is the one from our colleagues at Vanderbilt in Tennessee, which is that HEART tool. HEART because it's easy to remember. It's relatively simple and really contains all of the, I'm going to say, core elements of de-escalation. So H for hearing the patient, and the idea here and again, I feel sheepish saying this to a group like yourself, is actual active listening. So listening to learn from the patient as opposed to listening to respond to the patient, empathizing, showing that we care about them and what's happening to them. Sometimes A for apology. You don't always have to apologize. It's important to realize that an apology is not an admission of guilt. It's not saying, I'm sorry for having been negligent. I'm sorry for having botched your surgery. That is not an apology. An apology is simply, I am sorry this is happening to you. I'm sorry you've had to go through something like this. And again, it's more an apology that goes towards the compassion and empathy side, if anything else. Then the R is for respond, that negotiation, you telling the patient what's going to happen, how you're going to deal with this, and finding a common ground, a common plan with the patient. And finally, and very importantly, the T for thank you, which is to thank the patient for trusting you to share this information with you and to continue the care with you. Now, I would venture to say that most of the challenging conversations or the challenging encounters we have in medicine are not surprises. Most of the time, it's not a surprise when we walk into the room and, oh, whoa, this is a challenging conversation. It's usually the opposite, actually. It's usually back in the day when we had paper charts, a stack of charts, you look at the chart and you go, oh no, my God, that's going to be a tough conversation. And usually because your colleagues in the clinic have cherry-picked all of the easier ones, so you would be the one stuck doing it. And that fact alone is a good one because it allows us something which is a little period of time to be ready to prepare, to take 1 or 2 minutes before we go into the room to get ready, to take a big breath in, to think about the things that we're going to say, and very importantly, the things that we're not going to say. And there are tools to help us with that. For example, there's this website called Vital Talks, open access, anybody can go to it. And they have these quick guides for different types of encounters. And one of the encounters, as you can see, is conflicts. And when you click on the conflict, what it gives you is a nice little framework and some sample scripts. And the sample scripts are extremely valuable, I think, because again, you're going into a situation, and again, these challenging situations vary. This isn't true for every challenging situation, but the ones that are very challenging, where you know your emotions are going to get triggered, if you already know what you're going to say, if you're prepared with the right phrases, the conversation can go very differently. Now, I got very sophisticated too, so I said, what would be a faster way to do this? So I asked Perplexity, which is one of these AI interfaces. I said, Perplexity, I have a challenging conversation with a patient who wants me to fill a disability form. I can't really fill it because I don't think they fulfill the criteria. Can you give me a framework and some sample scripts? And I have to say, these are outstanding scripts that it gave me. I would use these anytime. Now, there's no lawyers from the CMPA here because they would probably be looking at me with big eyes going, oh my God, you're telling members to use AI? There are all kinds of important considerations around using AI. Obviously, you would never put patient information or identifiable information in this, but as a generic tool to help you pick the right kind of stuff, these tools can be very useful. And super accessible. I mean, that takes like 1 second. So you can go in well prepared. Now, there will be times where the patient is really upset. Maybe something really bad has happened, or maybe they're in a very high emotional state, or maybe there's been, significant harm, and you're just not able to de-escalate the situation. Well, what do you do in those cases? Sorry, too fast on the button. You use your judgment. And the first piece is, is your safety or your staff's safety a concern? And if it isn't, then what you have to do is basically name the behavior. You have to explain, name the behavior to the patient, say, you know what, using this type of language, using this tone of voice, whatever it is inappropriate. And the impact of it on the trust relationship and the potential that you'll have to terminate the doctor-patient relationship. And if you're going to do that, if you're going to consider ending the doctor-patient relationship, documentation is important. So again, you can't have a CMPA session without talking about documentation. Documentation in this particular set of circumstances is extremely important. And it needs to be very factual documentation. It can't be your emotional interpretation of what happened. It has to be just a representation, what was said, what are the facts of what happened during that conversation. And that'll be very important because if you do decide to terminate the doctor-patient relationship and the patient complains, and in those contexts there is a high likelihood of the patient complaint, you do want to have the evidence that you've made that effort to maintain the trust relationship. If, on the other hand, you feel that your safety and your staff safety is being threatened, again, still relatively rare, increasing in frequency, but still relatively rare, and sometimes specific to, very special environments. But if you feel your safety is being threatened, you need a plan ahead of time, actually. So this is something that you should have that exists in your environment, how it's set up, your exam rooms, that you have an exit route, that the patient's not blocking the door. Do you have security in the building, or are you in the hospital? Do you have to call the police? All of these things are policies that you have to have in place ahead of time. Just very quickly, because challenging conversations are often a prequel to terminating the doctor-patient relationship, a warning that every province's colleges have very specific rules around ending a doctor-patient relationship. And yes, an absence of a trust relationship is certainly a very valid reason for terminating the doctor-patient relationship. However, it doesn't necessarily mean you can abandon the patient either. So if you're in that situation, make sure that you consult the policies of your college. This was a nice, fast overview. Well, at least fast. I don't know about nice, but I'd encourage you to go to our website. We actually recorded a webinar on challenging patient encounters earlier this year. You can access it through the Education and Events tab on our website, and you can watch that at your convenience anytime. It gives you a little more information. Whoops. Thank you.